Have you ever wondered what happens when your body's master filtration system just, suddenly goes on strike?
It's a terrifying thought, honestly.
Right, because if you break your arm, the whole diagnostic process is just so comforting in its precision. I mean, the x-ray shows a clean, jagged white line. It's binary. The bone is broken or it isn't.
Yeah,
The
exactly.
doctor points to the screen, you get a cast, and you just move on. But today, we are stepping into this incredibly murky world of the human kidney, where that expectation of mechanical precision completely falls apart.
Oh, it really does.
We are doing a deep dive into a stack of nursing and medical sources covering acute kidney injury, or AKI, and our mission here is to understand exactly what happens when the kidneys suddenly quit.
Yeah, which is a lot more complex than people realize.
Totally. We're going to look at this fascinating three-part system of how things actually break down, the historical disasters that kind of forced medicine to figure this out, and I love this part, why some deeply entrenched textbook rules are currently being rewritten.
It really is a brilliant area to explore, because the kidneys are basically the ultimate silent partners in human physiology.
Right.
I mean, they are managing your blood pressure, they're balancing your electrolytes, they're fine-tuning your acid-base levels constantly.
Just doing all the heavy lifting in the background.
Exactly.
Right.
But unlike a heart attack, where, the patient has this crushing chest pain, the kidneys suffer in total silence. So the clinical challenge is that by the time you actually notice they're failing, the systemic damage is often just profound.
And that silent suffering, I think, leads us to this incredibly counterintuitive diagnostic reality, which is just a wild fact to me.
All the lab values.
Yeah. To diagnose a patient with a severe, potentially life-threatening acute kidney injury, you aren't looking for this massive catastrophic number on a lab report. You are looking for a microscopic shift. I mean, a change of just 0.3 milligrams per deciliter in a patient's serum creatinine.
Yeah, 0.3.
That's just a fraction of a decimal point. That is literally the difference between a lab value of 0.9 and 1.2.
Which, clinically speaking, is practically a microscopic margin of error.
Right.
I mean, if a patient just drinks a little less water one afternoon or, has a heavy meat-based dinner, their creatinine might fluctuate close to that amount naturally.
Wow.
Yet in the ICU, that tiny 0.3 shift within a 48-hour window, that is the threshold that triggers this massive cascade of medical interventions.
Okay, let's unpack this, because how did nephrology settle on a number that small? It kind of feels like hanging a massive diagnosis on a rounding error.
It does sound crazy, right? But to understand that 0.3 threshold, you really have to look back at the absolute diagnostic chaos that existed before it.
Chaos.
Oh, total chaos. Prior to 2004, there was literally no globally agreed upon definition of sudden kidney failure. None whatsoever.
Wait, that seems impossible for modern medicine. How are hospitals even tracking their outcomes?
Well, they weren't. I mean, not in any way you could actually compare. It was honestly a genuine scientific embarrassment.
Wow.
You have one hospital in New York, right? And they might define kidney failure as a massive doubling spike in creatinine, and they'd report a 5% failure rate in their surgical ward.
Okay.
But then a hospital in London might use a slight drop in hourly urine output as their metric, and they would report a 30% failure rate for the exact same types of surgeries.
So they weren't even speaking the same language.
Not at all. You had researchers trying to run clinical trials, but because nobody agreed on the basic definition of the disease, the data was entirely useless. We had this huge data comparability crisis.
So they essentially just had to lock themselves in a room and force a consensus.
Basically, yeah. In May of 2000, this group of leading nephrologists and intensive care physicians held a summit in Vicenza, Italy. And over the next decade, they hammered out a unified standard. So they published the Reifel criteria in 2004, then the Akin criteria in 2007, and finally the current gold standard from a group called KDIGO in 2012.
KDIGO, right.
Yeah. Kidney disease improving global outcomes. They're the ones who finally planted the flag on that 0.3 milligram per deciliter increase within 48 hours.
But alongside that numerical standard, they also force a massive semantic shift, which I find so fascinating. In 2007, the medical community deliberately stopped calling it acute renal failure and officially changed the terminology to acute kidney injury.
Yeah, and that is not just some PR rebrand,
Yeah.
Words dictate clinical action.
Right. Is it sort of like, if we use a car analogy, is changing the name from failure to injury like changing a total engine failure light on your dashboard to a check engine light?
That is the perfect way to look at it. Because for decades, the word failure implied this binary state, much like your broken arm analogy earlier.
Right. It's working or it's dead.
Exactly.
Yeah.
The assumption was either the kidney was working fine or it was completely dead and you needed a dialysis machine right now. But the epidemiological data were showing something far more insidious.
If we connect this to the bigger picture, what was that tiny zero point 0.3 bump actually indicating, if not total failure?
If we connect this to the bigger picture, it means the tissue is suffering. Like your dashboard analogy, failure was the engine smoking on the side of the highway.
Right.
But injury is the check engine light. The engine is still running, the car is still moving, but there is a distinct knock under the hood.
Wow.
What the data revealed was that even a mild transient dip in kidney function, that tiny 0.3 bump that maybe resolves in a few days, it carries real, massive, long-term mortality risks.
Even if they don't need dialysis.
Even then, patients who experience that tiny injury have measurably worse outcomes years down the road. So changing the name to injury forced clinicians to actually care about the check engine light instead of just waiting for the engine to explode.
Okay, so if we are looking at this check engine light, where is the actual mechanical breakdown happening? Because the clinical framework for understanding this, according to our sources, is the three-compartment model. So that's prerenal, intrarenal, and postrenal.
Yes, and it is the most elegant mental model for AKI. You just have to visualize the urinary system as a highly pressurized pipe attached to a pump.
Okay, a pipe and a pump.
Right. Blood flows to the kidney, it gets filtered through a microscopic mesh inside the kidney, and then the resulting urine flows out through a downstream drainage pipe.
Makes sense.
An injury can occur at any of those three distinct anatomical stages.
Let's look at the blood delivery first then. Prerenal AKI. Our deep dive notes say this accounts for roughly 55 to 60% of all cases, making it the most common. And the defining characteristic here is that the kidney itself is anatomically flawless.
Precisely. The kidney is totally healthy, but it is starving. Prerenal AKI is entirely a delivery problem. If you have severe hypovolemia, meaning, low blood volume from a hemorrhage or terrible diarrhea or severe burns, there simply isn't enough fluid in the pipes to push blood into the kidney's filtration system.
So no pressure.
Exactly. Or, alternatively, you might have plenty of blood volume, but a failing heart, like in cardiogenic shock, so there's just no pump pressure to move it.
Let's ground this in a concrete clinical scenario. Say you have an elderly patient who contracted norovirus. She has had severe vomiting and diarrhea for 3 days, hasn't been able to keep water down, and she arrives at the ER with a blood pressure of like 88/54.
Oh, she is profoundly volume depleted. Her kidneys are just desperate for perfusion. And in her lab work, you will see this brilliant physiological survival mechanism, basically disguised as an abnormal test result.
Oh, specifically the BUN to creatinine ratio?
Yes, the blood urea nitrogen. Usually that ratio sits around 10 to 1 or maybe 20 to 1, right? But in this severely dehydrated patient, that ratio will spike wildly, maybe 28 to 1 or even higher. The BUN just skyrockets while the creatinine rises much more slowly.
Why does the kidney selectively hoard the urea nitrogen but not the creatinine? Like, what's the mechanism there?
Because the kidney's structural tubules are still working perfectly. The body's central nervous system senses that her blood pressure is dangerously low, right?
Yeah.
So it sends a panic signal to the kidneys to save water at all costs. Urea is an osmotically active particle, meaning it drags water with it wherever it goes.
Oh, I see.
So the tubules aggressively reabsorb urea back into the bloodstream, using it as a magnet to pull water back into the vasculature and literally prop up her blood pressure.
That is incredibly smart.
It is. And creatinine, on the other hand, isn't reabsorbed the same way, so it just slowly filters out.
And you can see that same desperation if you look at her FeNA, the fractional excretion of sodium. Right?
Exactly. The FeNA measures how much sodium the kidney is letting escape into the urine. In a healthy person, it's usually between 1 and 2%.
Okay.
But in our dehydrated patient, her FeNA will drop well under 1%.
Wow.
The kidney is clamping down, just hoarding every single molecule of sodium it can find, because again, sodium retains water. It's literally trying to save her life.
Which means the treatment is incredibly straightforward. You give her intravenous isotonic fluids, you restore the volume, the kidney breathes a sigh of relief, and the labs normalize.
It is often rapidly reversible, yeah. However, this is where that nursing vigilance is paramount. You have to trend that hourly urine output and daily creatinine.
Because it can get worse.
Right, prerenal AKI is a temporary state. If you fail to give her those fluids and you let that hypoperfusion persist for too long, the kidney cells run out of oxygen. They cross the threshold into ischemia, which is actual cellular starvation and tissue death.
Oh, wow.
At that point, you no longer just have a delivery problem. You have structural damage to the kidney itself.
You've broken the filter. But before we get into the broken filter, let's look at the opposite end of the plumbing. Postrenal AKI, this is the downstream drainage problem, represent about 5 to 10% of cases.
Yeah, so if prerenal is a starved kidney, postrenal is a drowning kidney. The blood flow coming in is perfect. The kidney filters it beautifully, making perfectly normal urine.
What?
But that urine hits a physical roadblock on its way out of the body.
The classic textbook presentation here is what? A 78-year-old man with benign prostatic hyperplasia, an enlarged prostate.
Exactly.
He comes in, his abdomen is distended and painful, and a quick ultrasound of his bladder reveals like 900 milliliters of retained urine just backed up behind the prostate.
The plumbing is entirely blocked, and fluid dynamics dictate that pressure has to go somewhere.
Right.
So that 900 milliliters creates immense retrograde pressure. It travels backward, up the ureters, and physically compresses the delicate filtration structures inside the kidneys.
Just squishing them.
Basically. The pressure in the drainage pipe becomes higher than the pressure of the blood trying to enter the kidney, so filtration simply halts.
But the fix here is purely mechanical, right? You insert a Foley catheter past the enlarged prostate, the bladder drains immediately, the back pressure disappears, and the kidneys instantly resume filtering.
Yeah, you do have to monitor closely for post-obstructive diuresis, where the sudden relief of pressure causes the kidneys to just aggressively dump liters of urine.
Which could dehydrate them.
Right, which can accidentally swing the patient right back into prerenal dehydration. But mechanically, yes, the initial injury is resolved.
Now, regarding postrenal blockages, I have to bring up the surprising hook fact from the source material. There is a physiological quirk here that completely defies common sense to me.
Oh, the unilateral obstruction.
Yes. Let's say a patient develops a massive kidney stone, but it only lodges in the right ureter. So the right kidney is completely 100% obstructed. You would assume you'd immediately see an acute kidney injury on their lab work, but you don't. That is so counterintuitive that one totally blocked tube doesn't equal kidney failure.
It really is a beautiful example of systemic compensation. Assuming the patient has a healthy left kidney, unilateral obstruction rarely causes a spike in serum creatinine.
So the contralateral kidney just instantly picks up the slack without a blip in the systemic labs. Does it physically hypertrophy or just work twice as hard?
It just ramps up its glomerular filtration rate almost immediately.
Wow.
The healthy kidney realizes the overall systemic clearance is dropping, and it dials up its own filtration to clear the waste the right kidney is failing to process.
That is incredible.
So to see a postrenal AKI diagnosis on a blood test, you really either need a blockage in the urethra that backs up to both kidneys simultaneously, or you need an obstruction in a patient who only had one functioning kidney to begin with.
That level of biological redundancy is just staggering.
Okay, so we've covered the starved pipe and the blocked drain. Now we have to look at the middle compartment. Intrarenal, or intrinsic, AKI. This is where the structural mesh inside the kidney itself is physically damaged.
Right, the broken filter.
Exactly. It accounts for about 35 to 40% of cases. And here's where it gets really interesting, because the history of how medicine figured this out is incredibly dramatic.
It really is. It takes us out of the modern hospital and drops us right into the middle of the 1941 London Blitz.
Right. During the relentless bombing campaigns over London, these British physicians, Eric Bywaters and Desmond Beale, began noticing this terrifying pattern in the air raid victims.
Yeah.
These are people who had been buried under the rubble of collapsed buildings, often with their legs or arms pinned under heavy beams for 10, 12, 14 hours.
And the tragic part is the initial rescue would be a success. The patients were pulled from the rubble, their vitals were stabilized, and they seemed to have survived the worst of it.
Right. They were awake, talking, drinking tea on the ward. But a day later, their urine would turn this dark, muddy tea color. Massive edema would set in, and within a few days, they would die of sudden cardiac arrest or uremic poisoning. Bywaters and Beale termed this crush syndrome.
So how does a crushed leg cause a kidney to spontaneously shut down days later?
Well, Bywaters realized it was an issue of cellular debris. When muscle tissue is crushed for hours under a heavy beam, the muscle cells die and eventually rupture.
Okay.
When the pressure is finally lifted, when the rubble is removed, blood rushes back into that dead leg, and it washes all the toxic intracellular contents directly into the systemic circulation.
Oh, no.
And the most dangerous of these is a protein called myoglobin, which is found in muscle fibers.
And the kidneys, being the master filters, attempt to clear this massive flood of myoglobin from the blood.
Right. And initially, the top part of the kidney's filter, the glomerulus, handles it fine. The myoglobin slips right through.
But then what happens?
As that filtrate travels deeper into the nephron, into the distal tubule, the physiological environment changes. The distal tubule is highly acidic.
Okay.
When myoglobin hits that acidic environment, it undergoes a chemical change. It precipitates. It turns from a liquid into a dense, solid sludge.
Wow. It essentially casts the tubule in concrete.
Exactly. It forms these rigid casts that physically expand, clog, and completely destroy the delicate epithelial lining of the tubules from the inside out.
That's terrifying.
It is the textbook definition of rhabdomyolysis-induced acute tubular necrosis. The tubules are literally ripped apart by the very protein they're trying to excrete.
And this isn't just a historical artifact of World War II. Our sources note we see rhabdomyolysis today in extreme marathon runners who break down too much muscle tissue or military recruits subjected to extreme conditioning. Also in elderly patients who fall and lie immobile on the floor for 24 hours, and even as a rare side effect of high-dose statin medications. You look at their creatine kinase, or CK levels. A normal CK is under 200. These patients will have levels in the 50 to 100,000 range.
It is an overwhelming assault on the intrarenal architecture. But the truly tragic aspect of this physiology is how long it took for the global medical community to translate this understanding into modern disaster triage.
Yeah, you see this tragically play out in the history of disaster response, specifically during the 1988 earthquake in Armenia and the 1999 Marmara earthquake in Turkey.
Right. International teams of nephrologists arrived at those disaster zones and basically witnessed a mass casualty repetition of the London Blitz. People were surviving the catastrophic building collapses, making it to the triage tents, and then dying suddenly 2 days later.
What exactly was killing them so fast? Was it just the lack of filtration?
It was the specific consequence of the lack of filtration, which is hyperkalemia.
Potassium, right?
Exactly. When the crushed muscles rupture, they don't just release myoglobin. They release massive amounts of intracellular potassium into the blood. Normally, the kidneys excrete excess potassium effortlessly.
But they're clogged.
Right, because the tubules are choked with myoglobin sludge, the kidneys shut down, the potassium builds up rapidly in the bloodstream, and potassium dictates the electrical rhythm of the heart. When it gets too high, it triggers sudden fatal cardiac arrhythmias.
It's a silent killer because in a triage tent, the patient isn't bleeding out. They look stable until their heart just stops.
Those devastating earthquakes forced a total paradigm shift in how we handle crush injuries. Modern disaster response protocols now dictate that you do not just splint the leg and transport.
What do you do instead?
You mandate aggressive, immediate intravenous fluid resuscitation. You're literally attempting to flush the kidneys with high-volume saline before the myoglobin has a chance to settle and precipitate in the tubules.
Wow.
And crucially, you ensure that urgent hemodialysis equipment is available close to the disaster site to mechanically clear that lethal potassium.
History shows us catching up to the pathology, but that raises an interesting question. What are we getting wrong right now? Like, are there clinical dogmas regarding AKI that modern research is currently overturning?
Oh, absolutely. I mean, the science of nephrology is constantly revising itself. And perhaps the most significant current reversal involves intravenous contrast dye used in CT scans.
Okay, this one is fascinating to me because it challenges a foundational rule. For decades, the absolute standard has been, if a patient has reduced kidney function or a bumped creatinine, you do not give them IV contrast for a scan because it causes toxic acute tubular necrosis. Contrast-induced nephropathy was treated as an established medical fact.
It was a central pillar of clinical teaching. But what's fascinating here is that we are now learning that we may have fundamentally misunderstood the causality.
Wait, are you saying a golden rule of nursing that has been taught for decades might actually be based on bad data?
I am. 2 massive landmark trials, the AM Macing trial in 2017 and the PRESERVE trial in 2018, they threw a massive wrench into this dogma.
Because they found that aggressively hydrating patients beforehand or withholding the contrast altogether didn't actually change the rate of kidney injury. But if it's not the contrast dye destroying the tubules, Why were so many patients developing AKI right after getting a CT scan?
Because of a massive confounding variable that went ignored for 50 years. Think about the clinical reality. Who gets an emergency CT scan with IV contrast at 3 in the morning?
Highly acute patients. I mean, someone with massive trauma or a raging systemic infection or suspected internal bleeding.
Exactly. They're critically ill. So let's take a patient with severe sepsis who gets a CT scan on a Tuesday. By Thursday, their creatinine doubles.
Huh.
For half a century, the physician looked at the chart, saw the CT scan, and blamed the contrast dye. But what these recent better designed trials suggest is that the contrast dye was likely just an innocent bystander.
So the underlying illness caused the injury. How does sepsis mechanically cause the AKI if it's not the dye?
It goes right back to the prerenal compartment we discussed earlier. Severe sepsis causes systemic vasodilation. The blood vessels throughout the entire body widen dramatically, causing blood pressure to plummet.
So the kidney suddenly loses all its perfusion pressure.
Yes, it is starved of oxygen, ischemia sets in, and the tubules die. The sepsis caused the acute tubular necrosis, not the iodine in the contrast.
Wow.
Now, it doesn't mean contrast is entirely risk-free in profoundly advanced kidney disease, but the magnitude of the danger was vastly, vastly overstated.
It is such a sobering reminder that correlation is not causation, even in a textbook. And there are a few other common misconceptions that trip up clinicians. For instance, the assumption that if a patient is producing a normal volume of urine, they cannot possibly have an acute kidney injury.
Oh, that is a highly dangerous assumption. We frequently see a clinical presentation called non-oliguric AKI, especially when the kidneys suffer a toxic insult, like from certain antibiotics.
And do they still make urine?
Yes, the physical architecture of the kidney is severely damaged, and it has completely lost the ability to filter waste products like urea and creatinine out of the blood, but it is still mechanically pushing fluid through.
Oh, man.
So the patient might be producing 2 liters of normal-looking urine a day, but that urine is basically just water. It contains no waste. If you only look at the volume in the catheter bag and ignore the rising blood creatinine, you will miss a critical injury.
Another major misconception I saw in the sources is that an AKI diagnosis automatically means the patient needs emergency dialysis.
Yeah, that's not true either. Dialysis is actually quite rare in the grand scheme of AKI. The vast majority of cases, particularly the prerenal ones, resolve entirely with supportive medical care.
Like just restoring fluid volume.
Right, restoring volume, treating the underlying infection, and immediately stopping any nephrotoxic medications. We reserve dialysis for refractory cases that meet the AEIOU criteria.
AEIOU, right.
Yeah, severe acidosis, severe electrolyte imbalances like the hyperkalemia we discussed, toxic ingestions, extreme volume overload that diuretics can't fix, or severe uremia where waste products are actually affecting the brain.
You mentioned stopping nephrotoxic medications. That actually brings us to a specific pharmacological danger called the triple whammy. I have seen this term in clinical literature, but looking at the actual hemodynamics of how these 3 common drugs interact is just eye-opening.
Oh, it really is.
It is the combination of an NSAI, an ACE inhibitor, or ARB, and a diuretic.
It is a perfect storm for the prerenal clumping. And to understand why it's so devastating, you really have to look closely at the pressures inside the glomerulus, the actual microscopic filter.
Let's walk through the hemodynamics of this. Imagine the glomerulus as a highly pressurized water balloon with a faucet letting water in and a drain letting water out.
I like that.
To keep the balloon inflated and filtering, you need high pressure coming from the faucet, and you need the drain to be slightly constricted to keep the pressure up inside the balloon.
Exactly. The faucet is the afferent arteriole, the pipe bringing blood in. And the drain is the efferent arteriole, the pipe taking blood out.
So drug number 1, NSAIs, like over-the-counter ibuprofen. They inhibit prostaglandins. What does that do to the balloon?
Well, prostaglandins are molecules that normally keep the afferent arteriole, the faucet, wide open and dilated, ensuring strong blood flow into the kidney. When a patient takes an NSAID, they block those prostaglandins.
So the faucet clamps down.
Yes, you restrict the inflow of blood.
Okay, so the pressure in the balloon drops.
Right.
Then we add drug number 2, an ACE inhibitor, a very common blood pressure medication.
ACE inhibitors do the exact opposite on the other side of the filter. They block a hormone called angiotensin II. Angiotensin II normally acts to constrict the efferent arteriole. It tightens the drain, which helps maintain back pressure inside the filter.
I see where this is going.
When you take an ACE inhibitor, you block that constriction, so the drain flies wide open.
Oh, wow. So you have the NSAI clamping the incoming faucet shut and the ACE inhibitor throwing the outgoing drain wide open. The pressure inside the glomerular balloon just completely bottoms out to zero. Filtration completely stops.
Precisely. And then the third whammy.
Yeah.
You add a diuretic to the mix, which deliberately depletes the patient's total systemic blood volume.
Mm.
You have three distinct compounding mechanisms destroying glomerular perfusion pressure.
That is lethal.
If you give that combination to an older patient who is even slightly dehydrated, you're practically guaranteeing a severe prerenal AKI.
So we have mapped out this entire landscape. We've talked about microscopic lab shifts, blocked plumbing, crushed muscles in the blix, systemic compensation, and the danger of combining common medications. So what does this all mean for you, the listener?
I think the most critical paradigm shift in modern nephrology is understanding the AKI to CKD continuum. Historically, we thought of acute kidney injury and chronic kidney disease as two entirely separate entities. Acute was a sudden temporary dip that you recovered from. Chronic was a slow, permanent decline. But the data now shows they are deeply intertwined. Surviving a severe AKI episode is one of the most massive risk factors for your future health.
Wait, even if the labs completely normalize, like let's say that patient with norovirus gets her IV fluids and her creatinine goes right back down to a perfect 0.9, is she still at risk?
Yes, on paper, her AKI is resolved, but microscopically, that ischemic event left a scar. The nephrons don't heal perfectly.
Wow.
Studies definitively show that surviving an AKI episode measurably and permanently increases a patient's long-term risk for cardiovascular events, strokes, and the eventual development of end-stage chronic kidney disease.
Going back to your analogy, the engine didn't fail, but the check engine light came on, and the lifespan of the car has been shortened. Which perfectly underscores why bedside vigilance, specifically from the nursing staff, is the absolute front line of defense. Catching the slight drop in hourly urine output, or, questioning the resident who ordered an NSAI for a dehydrated patient, noticing that the BUN is starting to creep up. You aren't just protecting their kidneys for the duration of their hospital stay, you are literally defending their cardiovascular health for the next decade.
That vigilance is literally the only thing standing between a temporary physiological stress and permanent organ damage. But looking forward, the way we exercise that vigilance is about to change radically.
Really? How so?
Well, we spent this entire discussion focusing on creatinine, that tiny 0.3 shift, right?
Yeah.
But physiologically speaking, creatinine is a notoriously terrible lagging indicator. By the time serum creatinine actually rises, it means the kidney has already exhausted all its redundancies. The tissue has already been suffocating and actively dying for 24 to 48 hours.
Because it's too late.
Using creatinine to diagnose an injury is like looking at the ashes a day after the fire started. The damage is already done.
Wow. So what's the alternative?
The thrilling frontier for nephrology right now lies in novel, ultra-fast biomarkers, specific proteins like NGAL or cystatin C. These proteins are released by the kidney cells the exact moment they experience stress, hours or even days before the creatinine ever moves.
Like a real-time smoke detector.
Exactly. What happens to medicine when these biomarkers become the global standard? If we can see the kidney suffering minutes after a drop in blood pressure, we could intervene with fluids or medications so rapidly that we prevent the cell death entirely.
That would change everything.
We might eventually reach a point where the very concept of acute kidney injury becomes an artifact of the past, simply because we finally learned how to put out the fire before the smoke ever turns into a flame.
That is just a stunning evolution in how we protect the body's most silent, hard-working organ. We will certainly be right here to read the new clinical guidelines when that day finally comes. Thank you for joining us on this deep dive. Keep questioning the established dogmas, keep an eye on those leading indicators, and we will catch you next time.